Good evening, students. Good evening, everyone. I hope I'm audible. Please confirm if audio and visual are fine. So, welcome you all to the oral and maxillofacial surgery INI PYQ session. So, in this month, as well as in the next month, up till your INICET exam, which is on the 9th of November, all the faculties will be discussing the previous year's questions and the associated concepts so that you people are thorough specifically in the important or the most commonly asked topics in INICET. Good evening, HS. Good evening, Namisha. Good evening, Nikhil. Good evening, Shweta. So let's start. Okay. Now I want all of you to answer the questions in the comment section. Don't be afraid if you do not know something. This is what you are here for, to learn and to gain. So I'll start by reading the questions and the options. Let me know your answers. Also, please, I request you to mention the question number along with your answer so that I'm aware which question you have answered. Okay. So let's start with the first question. Consider the following in a TMJ examination of an adult patient. Which of these findings will be present in a disc displacement without reduction? So this question mentions 4 points and you have to pick all the points which are present in disc displacement without reduction. So the first is clicking on mouth opening and closing. 2 is deviation of mandible to the affected side. 3 is pain, and 4th is reduced mouth opening. So option A says 1, 2, 3, 4. Option B says 1, 2, 3. Option C says 2, 3, 4. And D says 1, 3, 4. So what would be the correct answer here? Good evening, Ritz. Ritz, I hope you have gone through my last session where I have explained your doubt regarding difference between displacement, deviation and dislocation. And I hope that is clear to you now. Okay, any more answers? Okay, I'm glad, Ritz, that your doubt was solved. Okay, so coming to this question, let's see this question. So it is asking you features of TMJ internal derangement, especially disc displacement without reduction. Now let us see, let us come to each and every point. So first says clicking on opening and closing. This is not seen in disc displacement without reduction. This is seen in disc displacement with reduction. Deviation of the mandible to the affected side. Yes, this is correct. Pain, yes. Pain is a feature of disc displacement without reduction. And reduced mouth opening or trismus is also a feature of disc displacement without reduction. So the correct answer is 2, 3 and 4. Okay. Now I have given the clinical features of both anterior disc displacement with reduction and without reduction in one of the previous sessions also, but don't worry, we will revise again. because this is a little difficult topic to understand. So we will just look at the clinical features again over here. Now the first column says anterior disc displacement with reduction. Okay. So there is pain during mouth opening. There is a click on opening. This is the most differentiating feature of disc displacement with reduction. And there is a click on closing, which is also known as a reciprocal click, and this one is usually less noticeable. Okay, this is less noticeable. Fine. And after initial 10 mm of mouth opening, there is deviation to the affected side. Okay. Now disc displacement without reduction. If you remember, in my previous video I have told you that in anterior disc displacement without reduction, the disc gets dislocated and it now lies in an anterior position in relation to the glenoid fossa as well as to the condyle, and it is stationary over there. So when a person is trying to open the mouth, the condyle hits against the disc. Okay, so the point where it hits against the disc is where the patient experiences pain, and since the disc is hindering the condyle, there is reduced mouth opening, that is trismus. And if the patient repeatedly tries to open the mouth against the displaced disc, it may also cause perforation of the disc. Okay, so let's see the clinical features. Disc interferes with condylar movement. I just now told you that it is hindering the condylar movements. There is trismus, and if patient tries to open mouth further, there is pain and there is deviation to the affected side. Okay, and can progress towards perforation of the disc. So very important points. There is no clicking over here, please remember. So there is trismus, there is pain on opening, there is deviation to the affected side, and if a patient continuously tries to open the mouth against the disc, there can be perforation of the disc. Okay, so I hope it is clear, all of you. Saurit, HS, SR, HK, I hope it is clear to all of you. Now the answer. If there are any doubts, please let me know. Coming on to question number 2. A moderately built young woman reported to you with complaint of intermittent headache, pain and clicking of TMJ. Identify the stage of internal derangement observed in this patient. A, stage 1, B, stage 2, C, stage 3 and D, stage 4. So this is a little difficult question. Alright, this is a question which has to do something with the classification of internal derangement, and the classification of internal derangement is usually taught in post-graduation. So this is a postgraduate level question. Don't worry, just try and attempt it. Okay, and I'll be telling you the classification of internal derangement. You can keep that in mind, you can memorize that, so that if there are such questions asked in the future, you can attempt them easily. Does anyone want to attempt this question? Okay, we'll see first. There is something known as Wilkes classification of internal derangement. Okay, so Wilkes divided the internal derangement into various stages. Okay, so this essentially you are expected to know this classification when you're doing your PG. Okay, so I'll just zoom out and we'll discuss. Okay, so stage 1. So there are 3 columns. You all can take a screenshot of this or note it down in your notes. So stage 1, and it has clinical features also given, and it has radiological findings also of the associated stages are also given. So stage 1 is early. There is painless clicking. Alright, please remember there is clicking, but there is no pain and there is no limitation of motion. Okay. Now, radiologically, there is slight disc displacement with early reduction and normal disc morphology. So there is slight displacement, and when the condyle is in motion, the disc reduces early. That is, during the initial stages of mouth opening only, the disc reduces back to its displaced position. Alright, so the disc has moved with the condyle, but as the condyle is opening further, the disc gets reduced to its abnormal position. Okay. Stage 2 is early or intermediate. Early or intermediate. So there is occasional painful clicking. That means there is occasional pain on mouth opening and occasional clicking on mouth opening. There is intermittent locking and related headache. Okay, this is your stage 2. What is it seen radiographically? There is moderate disc displacement with late the disc was normal morphologically. Now there is slight deformity and there is late reduction. Stage 3, intermediate. There is frequent pain, joint tenderness, restriction of motion and closed locks. Okay. Now this becomes disc displacement without reduction, because in stage 3 there is no clicking. That's why now this is classified as disc displacement without reduction. There is deformity of disc, but heart tissues are normal because there are no heart tissue changes. Okay. The next is 4th stage, which is intermediate or late, or somewhere between intermediate and late. There is chronic pain and restriction of motion. Okay, so there is pain and restriction of motion present always. There is severe disc displacement without reduction and severe deformity of disc and degenerative changes. That means now heart tissues have also started having changes morphologically. The last one is stage 5 or late. There is variable and episodic joint pain, chronic restriction of motion and associated with joint crepitus. Okay, so there is gross deformity, may or may not be associated with perforation of disc, degenerative arthritic changes, osteophyte deformity, subcortical cyst formation. So grossly, the joint, the heart tissues are also morphologically compromised. The morphological changes, gross changes in the heart tissues as well. So please remember, up till stage 1 and 2, it is disc displacement with reduction, and 3, 4 and 5 are disc displacement without reduction. Okay, so let's get back to our question. A moderately built young woman reported to you with complaints of intermittent headache, pain and clicking of TMJ. Identify the internal derangement stage. Now can you all answer? I'll not tell you the answer. Now I want all of you to answer, since I have explained the classification. Please answer this quickly, then we'll move to the next question. Yes, very good. Yes, very good. Great. Very good. Ritz, HS, Nikhil. The answer is option B, stage 2. Very good. Saurit, very good. SR, very good. Master Key, very good. Nimisha, all of you have understood this very well. I'm very happy. So please make a note of the Wilkes classification. Okay. Now, coming to the next question. Patient had recent trauma to his face and comes to you with bilateral diplopia and restriction of eye movements. What is the treatment in this scenario? Option A is orbital floor reconstruction with mini plate fixation. Option B is intermaxillary fixation. C is intraoral reduction of zygomatic bone, and D is orbital floor reconstruction only. What would be the answer here to question number 3? Sorry. Please try and answer even if you're not sure. It's okay. More answers? So yes, the correct answer is D, orbital floor reconstruction only. Okay, that is the correct answer. Let us see a little about orbital floor fractures and the reconstruction part, because questions can be asked. It is also known teardrop sign or teardrop appearance on PNS or CT scans. So this is your radiographically identifying sign. Okay. There is diplopia, binocular diplopia. That means diplopia present when seeing from both the eyes. Okay, binocular diplopia. And there is restriction in gaze. Okay, so these two things are indicative of entrapment of extraocular muscles. Which extraocular muscle? Inferior rectus, especially inferior rectus. And if in case inferior rectus is not given in the options, the next best to mark is inferior oblique. Okay, these are your all question points. So please keep this in mind. Okay, and how do you identify or evaluate for entrapment of extraocular muscles, or how do you identify the entrapment status? There's something known as a Hess chart and a force duction test. So I'll quickly explain this to you verbally. Hess chart is you ask the patient to look in 9 directions. So first straight, then superior, then inferior, then right, then left, then superolateral, infерomedial, superomedial, and inferolateral. Okay, and that is how you identify if there is any restriction in gaze. All right, if there is less movement of the eyeball in any one particular gaze. Okay, force duction test. Force duction test is usually done by ophthalmologists. So what is done is you retract the lower eyelid, catch hold of the inferior rectus muscle with a very fine tooth tissue holding forceps, and you try to elicit movement of the eyeball. So if there'll be entrapment, there'll be no movement, or there'll be restriction, or there'll be resistance by the muscle, because if it is entrapped in the orbital floor fracture. Okay, so these are the two tests, Hess charting and force duction test. They tell you about the entrapment status. They confirm the entrapment status. Okay. Now the treatment is orbital floor reconstruction. Okay, the treatment is orbital floor reconstruction. Now I have a table over here which tells you some of the materials. This is not the complete list, but these are some of the materials that you can use for an orbital floor reconstruction. These are the most important ones that are needed at your level. Okay, so you can do a autologous orbital floor reconstruction. In bone, you can use the calvarium or you can use the iliac crest. You can use patient's own cartilage, septal cartilage or auricular cartilage, that is the ear cartilage. Allogenic material, you can use irradiated bone, bovine bone or lyophilized cartilage. And alloplastic, that are synthetic materials. Non-metallic ones, you can use silastic sheets. Silastic is nothing but it is a polymer of silicon. You can use Teflon. And metallic permanent implants that you can use are made of titanium. Okay, so these are some of the materials that you can use for titanium mesh. Okay, you get a mesh, you can cut the mesh as per the size and contours of the orbital floor, fix it with screws. You can either just leave it there or you can just extend this mesh down below and fix it here with screws. Okay, and these two are preformed orbital floor plates. Okay, so they are preformed, they are contoured beforehand, they have a side to themselves. So here, if you can see, if I zoom out, this is the right side one. Okay, so they are contoured beforehand while manufacturing. They are given the shape of the orbital floor and they have wings. So here you can just bend them on the infraorbital rim and secure with screws over here. Okay, so there is no role of manipulate in orbital floor reconstruction. It is just done either with help of titanium or allogenic material or autogenous material. Okay, coming on to the next question. Question 4. A male patient is currently under warfarin medication. He is scheduled to undergo an extraction. How will you manage? A. Stop warfarin 5 days before. B. Stop warfarin 5 days before and maintain INR value of less than 2.5. No dose alteration and no need of INR value. D. Maintain INR value of less than 2.5. So what would be the answer here? No, it's the same. It's the same. Whether it is capital R or small r, Spidey's log, it's the same. So different manufacturers have their own ways of writing it. So R, irrespective of its font or size, is always right, and L, irrespective of the font shape or size, is always left. Okay. I hope your doubt is clear. So what would be the answer here? Question number 4. Any answers here? Yes, the correct answer is maintain INR value of less than 2.5. Okay, so very good, Nimisha, SR, Nikhil, and Saurit. So let's just see if a patient is on warfarin, what you will do, especially if the patient is planned for a minor oral surgical procedure. Okay, check INR within 24 hours. Yes, very good, Ritz. Check INR within 24 hours. So let's say, for example, if the patient is scheduled for extraction tomorrow morning at 10 a.m. Okay, so 24 hours prior to the procedure, you have to get a INR value. So check 20 INR within 24 hours, that is prior to procedure. Remember, we are only talking about minor oral surgical procedures right now. Okay, so 2.5 to 3 is considered as the safe limit, and ideal should be less than or equal to 2.5, the INR value. Okay, now how do you take decisions? If the INR is less than equal to 2.5 or between 2.5 and 3, you can proceed with the extraction. If the INR is more than 3, you defer and consult the patient's physician or the cardiologist or whosoever has given the anticoagulant to the patient. Okay, do not stop warfarin for minor oral surgical procedures. Do not stop warfarin for minor oral surgical procedures. Please remember, the protocol, the latest protocol is not to stop anticoagulants for minor oral surgical procedures. Okay, what you have to keep in mind is you have to do a atraumatic extraction with local hemostatic measures. So you have to make sure that you have achieved good hemostasis, the bleeding is under control, and you have to give local hemostatic agents so that the bleeding is under control and the clot stabilizes well. Okay, so this is for these values are important. Please remember them. Coming to question 5. A patient who's got his tooth extracted 1 month back came to you with a complaint of Oroantral fistula of 1 centimeter in diameter. What is your immediate treatment plan for this patient? A. Distant flap for closure of fistula. B. Splint indefinitely. C. Splinting of fistula and treat chronic sinusitis. And D. Excision and tight closure. What would be the answer here? Yes, very good. Others also please answer. Yes, so the correct answer is splinting of the fistula and treat chronic sinusitis. Those of you who have not understood, I'll explain. Let's read the question. Patient got tooth extracted 1 month back. 1 month back, that means the condition has become chronic. Okay, so very good, you all have got this correct. So the condition has become chronic. He came to you with a complaint of a oroantral fistula of 1 centimeter. Now please remember, don't get confused, it's a fistula. Fistula is a epithelialized tract. Now when it is an epithelialized tract, the size does not matter, whether it's small, whether it's large, you have to excise it. Okay, you have to excise it. Now since the condition is 1 month old and there is a epithelialized tract which is now a oroantral fistula, so there is continuous ingress of saliva and debris into the sinus, into the maxillary sinus. So what will the patient develop? The patient will develop chronic sinusitis. Okay. Before you have to close this, you have to treat this. You have to do the treatment for chronic sinusitis. Before you decide to, because it is an infected cavity, you cannot just go and excise the tract and close it. You have to get the inflammation under control. So you have to treat the chronic sinusitis first. So you will treat chronic sinusitis. Now, while treating the chronic sinusitis, you will splint the fistula, because now you want to stop the entry of saliva and food debris into the sinus. Only when you have stopped it, along with simultaneously treating the chronic sinusitis, will you achieve results. Okay, so it is the first immediate step. The first most important step is to stop or seal the sinus, stop the ingress of contaminants into the sinus, seal the sinus cavity and treat it for chronic sinusitis, and then proceed for excision followed by flap closure. Okay, so this is the concept. You will always treat sinusitis first, stop the causative agents of sinusitis, and then proceed further. Let's get on to the next question, that is question number 6. A 2-year-old child suffered a fall from the cot. Her mother brought her to the hospital. On examination, there is a slight tenderness over TMJ. What should be the treatment? A. Nothing to be done as there is no injury. B. Restriction of movements. C. Aggressive mouth opening exercise. And D. Cap splinting. What would be the correct answer here? Answer to question number 6. More answers? So yes, the correct answer is aggressive mouth opening exercise. Aggressive mouth opening exercises. Now, just for explaining, a 2-year-old child suffered a fall from the cot. Her mother brought her to the hospital. On examination, there is slight tenderness over TMJ. They have not, apart from tenderness, they have not mentioned any other sign and symptom of whether there is a fracture, okay, or whether there is an injury. So when they have not mentioned anything, what you would advise to the child's mother would be aggressive mouth opening exercises. Why? Because since there is tenderness of the condyle, you want to make sure there is no, that the patient does not go into ankylosis. So this is done to prevent TMJ ankylosis. Okay. So very good, Ritz, Nikhil, HS and HK. You all have got this correct. Coming to the next question. Which type of tube is suitable for submental intubation? A. North Pole RAE. B. South Pole RAE. C. RAE. And D. Tracheostomy tube. So what would be the correct answer here? Please mention the question number also when you all are answering. Yes, very good. South Pole is the correct answer. Okay. A few points regarding submental intubation. Okay. This is also known as Altimere's technique. Altimere's technique. Okay. It was first described by Francisco Hernandez Altimere in 1986. Okay. So the tube is passed through anterior floor of mouth. I also have a visual that you can see on your screen. The incision is given in the submental region. The indications are panfacial fractures and orthognathic surgery. The contraindications are wound on the floor of mouth and patient who requires prolonged periods of assisted ventilation. That means the patients who need to be kept intubated for a very long period of time, in them we cannot do a submental intubation. Okay. Now, very important, if they ask you the choice of tube, please always give preference to marking flexometallic over south pole RA. Please keep this in mind. I'll tell you why. Because if I zoom this out here, a south pole has a bend towards the foot end of the patient, right? It has a bend towards the foot end of the patient. So that bend will cause hindrance over here. It'll go and touch the chest area of the patient. Okay. So the first preference, rather always a submental intubation is done with a flexometallic tube. If only flexometallic is not given in your options, please go with south pole RA. Okay, is it clear to all of you? Please remember this. Now quickly about south pole and north pole tubes. So this one is a north pole tube. It is also a nasal tube. Okay, so it is used for surgeries in the maxillofacial region and surgeries of the TMJ. Okay, this is a south pole tube or a oral RA. This is used for neurosurgical procedures or when you're operating on the head or when you're operating on the nose. So this has a bend towards the foot end of the patient. Okay, so if you see, more convenient for submental is the flexometallic tube followed by the south pole tube. And just to explain, the head end of the patient is always north. So the bend is towards the head end of the patient. That tube is known as a north pole RA. The foot end of the patient is always south. So the bend, when the preformed bend is facing towards the feet, it is a south pole or a oral RA. Now these are two tubes. Okay. What you will have to do is, if you are just given the tube and you have to identify in the exam, you will have to imagine. Okay. You will have to imagine a patient. Let's imagine you have taken the patient in this particular direction. Okay. Now you will have to imagine that this is going into the trachea. If this end is going into the trachea, this is bending towards the head. So this is a north pole RA. So you will have to imagine, if you're just, I'm talking in case in the exam you're just given the tube and you're asked to identify whether it is north or south. And if this goes inside the patient's trachea, you can see that this curve is bending towards the foot end of the patient. So this is a south facing RA or a oral RA. Is it clear to everyone? In case when you're just given the tube, how will you identify? Okay. So the cuff, you will imagine that the cuff is going into the trachea. You will imagine a patient, you will you will have to orient yourself. You'll have to get your imagination working in the exam hall, and then please answer carefully, keeping where the preformed bend is pointing in which direction. Coming to question number 8. A 55-year-old male patient, chronic smoker with gross swelling of the left lower jaw, reported to the dental surgeon. On examination with OPG, fracture of the mandible is seen. What is the first approach in management of this patient? A. Screws and mini plates. B. IMF with antibiotics. C. Load bearing reconstruction plates. And D. Biopsy. Okay, Ritz, I'll show it in the next class because I am not carrying the visuals for flexometallic tube and fiber optic intubation. I'll get them in the next session, which is on the 11th. Okay, we have a oral surgery session scheduled on the 11th. I'll get you the visuals of flexometallic and fiber optic intubation also. Okay, flexometallic you can see here also. This is a flexometallic tube. It is just a normal endotracheal tube which does not have any bend. Okay, you can, a part of it you can visualize in this particular picture, but I'll definitely show you the other visuals also. Yes, so what would be the answer to question number 8? Okay, let's understand the question. 55-year-old male patient, chronic smoker with gross swelling of left lower jaw. Okay, and on examination you see a fracture of the mandible. What is the first approach? Please note, there is no history of trauma given in the patient. I'll zoom out this OPG. There is no history of trauma given in this question. I'll just finish this question and take your doubt, Nikhil. Okay, no history of trauma is given over here. So there is a chronic smoker. So the patient has a habit which can cause a lot of sequelae. There is gross swelling of that region, and then there is a fracture. So that means there is a pathology. Now, to identify the nature of the pathology, you have to do a biopsy. Now, when there is a fracture, okay, this can be either a pathological fracture. I'll write it here. It can be either a pathological fracture, okay, or it can be erosion or invasion of bone. Erosion or invasion of bone due to the pathology. Alright, so this is this sign is very suspicious for a malignancy. This sign is very suspicious for malignancy. So to identify the nature of the ongoing process, to figure out what is happening with the patient, you will do a biopsy. Okay, understood? HS, SR, HK, is it understood to all of you? Please let me know. Now I'll take this out. For panfacial trauma, will we prefer tracheostomy or submental intubation? So see, clinically, if I have to tell you theoretically, if you're just asked for panfacial fracture, you will always go for a submental intubation, because tracheostomy is a more invasive airway. It is a surgical definitive airway. So there are obviously more complications associated with that. In patients where they also have concurrent, neurosurgical injuries, I'm talking clinically, where there are concurrent neurosurgical uh, issues, where the patient is not, where you think that the patient is not going to recover soon, where the patient will not be able to breathe or maintain the airway on his or her own for a long period of time. In that case, you will do a tracheostomy. Okay, so especially when in pan-facial trauma patients who require prolonged assisted ventilation till the time they can return to breathe or maintain their airway on their own, in that you will prefer tracheostomy. I hope your doubt is clear, Nikhil. So coming to question number 9, a patient noticed a slow hard growing swelling in the maxillary molar region with displacement of teeth. Which of the following will be useful in final diagnosis? A. FNAC, B. Biopsy, C. Urine microscopy, and D. X-rays. So what would be the answer here? Please answer. We just did a similar question. Okay, so let me explain. Slow, hard growing swelling. Hard growing swelling. Okay, in the maxillary molar region with displacement of teeth. What will be the most useful thing in the final diagnosis? So you have to confirm your diagnosis. There is no role of urine microscopy. Okay, it has nothing to do with this. There is no role of X-rays also. X-ray is just going to tell you the radiographic feature. On the basis of X-rays, on the basis of imaging, on basis of radiography, you never arrive at the final diagnosis. Okay, so you are remaining with option A and B, FNAC and biopsy. Now, since it is a hard growing swelling, hard swelling, FNAC is also not indicated. So the correct answer is biopsy. Okay, understood? HS, RITS, understood? Let's go on to the next question. The following instrument is used for osteotomy: A. Osteotomy, B. Sequestrectomy, C. Maxillary anterior tooth extraction, and D. Corticotomy. Very good, HS. So now you see, when I'm reading out the questions, I am telling you how to read the question also. If you all are observing how I am picking out the keywords, how to read your question in the exam, and how to arrive at your answer. I hope you all are learning that. This is what these sessions are for. Okay, these sessions are to make you practice better and make you gain confidence so that you can identify what to pick out from your questions and how to answer your questions. What would be the answer to question number 10? Any more answers? So the correct answer is sequestrectomy. Okay, the image given is that of a bone rongeur. Bone rongeur. Okay, so yes, very good. All of you have got this correct. This is a bone rongeur, and this particular one is also known as the Blumenthal rongeurs. Blumenthal rongeur, and this has been asked previously in NEET, I think in 23 or 22, if I'm not wrong. Yes, bone rongeur for bone contouring. Absolutely correct, HS. So this is a surgical instrument resembling a heavy duty scissor or forceps. It has a spring mechanism. Please remember, your artery forceps, they have a locking or a ratchet mechanism. This has a spring mechanism and a sharp scoop shaped jaws at the end. Okay, now most important, the uses: to cut and shape bone by grasping and removing small bony fragments or irregularities after multiple extractions. So when you have done multiple extractions and when there are irregular interdental bones or interradicular bones which are remaining, which are sharp, you remove them with the help of bone rongeur. Okay, for precise trimming, contouring and removal of bone, like while doing a alveoloplasty. To trim a harvested bone. What does this point mean? Once you have taken out or harvested the graft, and now you want to shape the graft, or you want to remove the irregularities from the graft, or you want to just trim it slightly so that you can get the correct dimensions, then also you can use a bone rongeur. Okay, so to trim a harvested bone graft and removal of dead necrotic bone, that is nothing but your sequestrectomy. So these are the uses. Please keep in mind. Coming to the next question, patient was advised CT imaging for a certain TMJ disorder. He had reduced mouth opening. What is the diagnosis? A. TMJ arthritis. B. Ankylosis of TMJ. C. Normal anomaly. D. Condylar fracture. So there is a marked arrow in the radiograph. What diagnosis would you make on the basis? So this is a CT scan, a coronal section of the CT scan. Very simple, straightforward question. I want everyone to answer. Who's all are there in the live session? Please answer. Very good. Everyone has got this correct. It is a ankylosis of TMJ. Now, since we have this question, we will very quickly revise Sawhney's classification, because it is also the radiological classification of TMJ ankylosis. Yes, very good, HK. All of you have got this correct. The Sawhney's classification based on radiological findings, or Sawhney's radiological classification of TMJ ankylosis. So type 1 is mild fibrous ankylosis of condyle with glenoid fossa. So when you have mild fibrous ankylosis, the anatomy is intact. You can make out the outlines of the glenoid fossa and the condylar head very nicely. So this is how it looks like. The anatomy is intact. Okay. Now, coming to type 2, Type 2 is mild bony fusion of condyle with glenoid fossa, or minimal bony fusion between the condyle and glenoid fossa. Anatomy of condyle, coronoid and sigmoid notch is still appreciated. Here also you can appreciate the anatomy. Okay, if you see here, you can still appreciate the outlines of the condyle and the glenoid fossa. Type 3 is the most common type, and fusion occurs just lateral to TMJ. So laterally between the condyle and the glenoid fossa, alright, on the lateral aspect there will be a bony bridge, alright, which is also known as the juxta-articular type of ankylosis. Juxta-articular. Okay. So laterally you cannot appreciate the anatomy, but medially you can appreciate the condyle, the glenoid fossa. Okay. So medially glenoid fossa and condylar anatomy can be appreciated. So there will be a lateral bony bridge, also known as juxta-articular type. Lateral bony bridge. Okay, medially the anatomy of the condyle you can appreciate. Type 4 is severe bony ankylosis, lack of identifiable landmarks. You cannot identify the condyle, the glenoid fossa or the sigmoid notch. You cannot identify any anatomic landmarks. So there would be a bony bridge. Complete fusion. This is known as complete fusion. Okay, that is your Sawhney's classification. Okay, I have to explain this in my class also. Fine. Now, coming to the last question of our session, and it says, what is the diagnosis in the given image? A. Vertically unfavorable fracture. B. Horizontally unfavorable fracture. C. Comminuted fracture. D. Compound fracture. What is the answer here? I have taken a similar question in my last MCQ edition also, and I have also told a trick. So if anyone can tell me the trick to remember horizontally favorable and unfavorable. So I want the answer also. Very good. Can someone also tell the trick? I told you a trick, an easy trick how to remember horizontally favorable and unfavorable. Horizontally unfavorable fracture is the correct answer. Let's see. I'll tell you the trick again. So I've told you, whenever we say it's a horizontal fracture, we always see it from the lateral aspect or at the horizontal axis of our site. Okay. Okay, HS, understand. How is it horizontally or vertically? Okay. Yes, Ritz, that is stage Sawhney's type 4. Yes, that is correct. Okay. Now, HS, understand vertically or horizontally, and also understand favorable and unfavorable. Whenever you are viewing the mandible from the lateral aspect, whenever you're viewing the, let's see, this is the mandible, the remote, okay, when you're reviewing this from the lateral aspect, so you are viewing it in the horizontal axis, so it becomes horizontal, it becomes horizontal. Okay, if you are viewing the mandible from the top, okay, if you're viewing the mandible from the top like in an occlusal radiograph, so you're viewing the mandible in your vertical axis, so it becomes vertically. Okay, now favorable or unfavorable, I will just tell you for horizontally right now. Vertically, maybe in the next session, 1 or 2 sessions, I'll take up another question and I'll explain you, because without diagrams or images I cannot explain you vertically favorable or unfavorable. Now when you are viewing, we will talk about horizontally right now. Okay, horizontally you always have to see that the fracture line, the direction of the fracture line. Now when you trace the direction of the fracture line, you always have to trace it from the superior border to the inferior border. Always please remember, from the superior border to the inferior border. Okay, if the fracture line is traveling, the fracture line will always travel downwards from superior border to inferior border. Okay, now it is traveling downwards. Now how is it oriented? From the superior border to the inferior border, if it is oriented backwards or posteriorly, like how it is in this image. Okay, so if the fracture line is backwards or posterior, it is an unfavorable fracture. This is just to remember the concept between favorability and unfavorability. I'll tell you in the next session, or maybe any session before INI. Okay, so, and if this fracture line is forwards from the superior border to the inferior border, if it is forwards, then it is favorable. Okay, this is the trick that I'm telling you to remember. So the trick is, favorable forwards. So if the fracture line is forwards, it's a favorable fracture. Okay, and backwards is bad. Backwards is bad. So backwards is D. D for displaced. And a displaced fracture is unfavorable. Okay, and the displaced fracture is unfavorable. Okay, this is the trick to remember. So don't worry, I will again tell you horizontally favorable, unfavorable, or vertically favorable, unfavorable before your exam. Either I'll tell you in one of the INI series, or we will also be having a predictor series. I'll either tell you there. Similarly for intubation, we will revise intubation either in one of our sessions, or we will revise intubation in the predictor series. Okay, so don't worry, we will revise whatever your doubts are. Nothing will go pending, nothing will go unanswered. I will take care of these things in one of our sessions, or during our predictor series. Also, in case of unfavorable, there will be displacement. Yes, just now I told you, when it is backwards, you remember that it is bad. D stands for displaced, and it is unfavorable. I just now told. Just remember it like this. Okay, remember this trick. Is your doubt clear, Ritz? Very good, HS. Ritz, is your doubt clear? So don't worry, students, you all are doing well. Okay, you all are on the right track. Just keep on revising, and I'm sure you all will do well in your exams. Okay. So with that, I leave you with the upcoming schedule for the coming week. Thank you so much, Ritz. Thank you for your kind words. These are your upcoming sessions. So please take a note of your upcoming schedule. Happy studying, dear students. Don't stress and panic, and keep studying, keep working hard. I'm sure you will get where you want to, whatever you desire. Why not compound? Yes, it's a compound fracture, but it's not given in the options. So that is why it's not in the option, so that's not our answer. But yes, the image given is of a compound fracture because the PDL space is involved. Is it okay, Nikhil? Have you understood? Yes, it is in the tooth bearing region. So it is a compound fracture. It is a compound fracture, but if you ask me what to mark between the two, the better classification is yes. Okay, I got back to the question. Compound is given, it is given, but if you, the better classification is a horizontally unfavorable fracture because there is displacement. It is an angle region fracture. Okay, if you see carefully, it is an angle region fracture, and so whenever you are given a question like this, you have to pick the classification which gives the best clarity, or which is because if you go back to the classification, the notes where I've taught you the classification, simple, complex, compound, green stick, pathological, that is a very general classification of all the fractures. Okay, whereas horizontally unfavorable, favorable become very specific to angle fractures. That is why you have to mark that. Okay, is it clear, Nikhil? So please let me know so that we can wind up this session. I hope all doubts are taken care of. Also, please note the schedule for the next week. I'll see you all again next week. Thank you for joining in. Happy studying.